Dear friends and colleagues, so thank you very much for being here today with us discussing fetal neurosonography. And this session, it was about first trimester fetal neurosonography. We went through different conditions potentially affecting the fetal brain in the first trimester. And now the topic of my talk is to give you an overview on the first trimester fetal neurosonogram. And of course, we will do that doing through the anatomy, to the imaging assessment from the second to the first trimester to see whether actually what we can see in the second trimester and what it has been actually suggested by ISWOG tool to be described in the brain in the second trimester can be actually applied in the first trimester. And we will do that actually going through different types of anatomical structure, the supratentorial structure and the infratentorial structure. So let's start from fetal neurosonography. So we know that classically detailed assessment of the fetal brain through a multiplanar mode has been suggested to ISWOG to be undertaken, especially in the second trimester in fetus at risk of fetal anomalies or with ultrasound suspicion of fetal anomalies at the standard axial view of the fetal brain. So we know that this is especially accomplished by obtaining different sessions, so different imaging plane, either in the axial, coronal, and sagittal view of the brain. And let's start with the supratentorial anatomy. So let's see whether we can assess the supratentorial anatomy in the first trimester in the same way actually we do that in the second trimester of pregnancy when we do the standard fetal neurosonography. And when we look at the anatomy, of course, we start from the axial plane of the brain and then we go through the coronal and sagittal view of the brain. And what we can see in the axial transventricular plane of the brain, which is the primary plane on which we actually suspect diagnosis, which can suspect anomaly, which can potentially affect fetal brain, is that we have to see the interhemispheric fissure, the anechoic or trapezoidal cavum septi pellucidi, the anechoic frontalors with the medial wall of the frontalors being close but not fused with the cavum septi pellucidi, which means that the medial wall of the frontalor should approach the box of the cavum septi pellucidi. And we see the third ventricle and then symmetric posterior ventricle with a slightly hyperechogenic chorioid plexus. And at least if we see the normality of this imaging complex, we might say is with a good level of agreement of confidence that the fetal brain, the supratentorial brain anomaly is normal. So let's translate these let's go to the imaging. So can you see this is a standard axial view of the fetal brain in the second trimester. As I can see, it can tell you what we can see is the anechoic corpus callosum, rectangular or trapezoidal, the two pair frontalors, which are also anechoic, and we can see the third ventricle. This tiny fissure is the third ventricle with the two thalami. And this is what actually we have to see in the second trimester for the supratentorial view. Of course, in order to perform neurosonography, we should shift from the axial to the sagittal and coronal view of the brain, because we know that some structure can be visible all in the sagittal view of the brain, and this is the case of the corpus callosum. As you can see, this comma-shaped structure with two hyperechogenic lines. So this anechoic structure here is the cavum septi pellucidi, and this is the third ventricle. Here is the chorioid plexus of the third ventricle. We actually tell us that we are on a perfectly sagittal view. When we assess the corpus callosum, of course, we have to look at the different anatomical structure, especially the anteroinferior part of the corpus callosum and the posterior inferior one, which are respectively the rostrum and the splenium. And we know that in order to accurately describe the anatomy, this is something that I personally do not do clinically. We can apply color Doppler to look at the curves of the pericallosal artery, which actually follow the entire length. I would not say the entire length because it does not follow the most anterior part of the corpus callosum, but at least the majority of the length of the corpus callosum itself. And we complete the anatomical assessment in the second trimester by looking in the coronal view of the brain, which more or less we can see the same structure, which we can appreciate on the axial plane, which are the interhemispheric fissure, this hyperechogenic line here, which is perpendicular to the interhemispheric fissure, which is the circle with the callosal circus. Beneath that, there is the hypoechoic corpus callosum, the two pair frontalors, anechoic frontalors, and the rectangular or trapezoidal cavum septi pellucidi. So now the question is, can we recognize the same structure during the first trimester of pregnancy at the time of the 11 to 14 week scan? So before doing that, We know that there is an ongoing body of evidence on the first trimester fetal neurosonography, with several papers published in the last decades, either on the assessment of the supratentorial and infratentorial structures. The problem with first trimester brain assessment is that there is no a huge body of evidence on how to assess it. Of course, there is some suggestion also from ISWAG and other society to use, especially to preferentially use high-frequency transvaginal probe. Another problem is that in most of the case, most of the published studies included cases with associated anomalies, and we recently did a systematic review in which we computed up to 95% of cases presented in the studies on first trimester fetal neurosonography had associated anomalies. So in this case, the diagnostic accuracy of ultrasound might be biased. Another main issue is the specificity. I don't know, the other speakers have extensively gone through that. The first trimester neurosonography has a low specificity, and it is especially for condition affecting the infratentorial structure, especially of course, cerebellar vermis. So when we assess during the second trimester the normality of the fetal brain, this is an algorithm we use in our clinic. We used to ask ourselves a series of clinical relevant questions. And the first one, is the calvario normal? Are the cerebral hemispheres symmetric? Is the interhemispheric fissure present? Is the cavum septi pellucidi normal, which means it's visible, rectangular, and anechoic? Are the frontal lobes of the lateral ventricle adjacent to the cavum septi pellucidi? Is the third ventricle normal? Does the brain parenchyma is a normal echogenicity? Is the periventricular area of the brain normal? So let's try to see whether we can apply this imaging algorithm to the first trimester of pregnancy. And of course, what is actually very easy and straightforward to diagnose is the absence of the cranial vault, So we know that when there is in some condition extensive cranial defect which leads to the direct exposure of the brain to the amniotic fluid is what is being called acrania, exencephaly, anencephaly sequence. In this condition, which can be easily recognized as 2D or 3D ultrasound, we cannot see the fetal profile, and we can see the brain, which is completely disorganized, is exposed to the amniotic fluid. We can use either 2D or, as in this case, 3D ultrasound, in which can you see there is a complete absence of the cranial vault. And this is also other magnified picture, which means that, of course, at least for what it is the first step of assessment of the fetal brain, it can be also recognized during the first trimester scan. And the second step, when we assess the integrity of the brain, is also not just to look at the cranial vault, but also to look at the integrity of the cranial vault, especially in the posterior part, because we might have sometimes a defect in the posterior part of the brain, the so-called encephalocele. As can you see, we have the normal appearance of the parietal bones, but when we go and access the occipital bone of the brain of the calvarium, we can see that there is an opening here with direct exposure of the direct herniation of the fetal brain in the amniotic fluid through the meningeal tissue. And of course, it is very straightforward. We know that most of the conditions which affect the cranial vault can be easily diagnosed in the first trimester, but let's try to see whether we can apply the same imaging algorithm we use in the second trimester to the first trimester. So, and the other question is about the interhemispheric fissure. So we know that the interhemispheric fissure is one of the early of the structure of the fetal brain, which can be recognized since very early in pregnancy, since the 9 weeks of gestation. And of course, this is a video obtained through the high-frequency transvaginal probe. And can you see, in this case, we can see the two hemispheres are symmetric, that there is the hyperechogenic interhemispheric fissure. We cannot see the frontal horn adjacent to the cavum septi pellucidi, because in this video, in this picture, in this case, we could not see the cavum septi pellucidi, but we see that the lateral ventricle entirely fill the cranial vault, and within the lateral ventricle, we can recognize the choroid plexus with its homogeneous and actually fill the posterior and medial part, but not the anterior part of the frontal horns. So what it should be described when we do a scan is, of course, the presence of the interhemispheric fissure and the fact that the choroid plexus homogeneously fills the cavity of the lateral ventricle. And why is this important? Because also in this case, very easy to recognize in the first trimester, we might see a condition like that in which there is no interhemispheric fissure. We have just one ventricle, the so-called single ventricle or hollow ventricle. There is no, as I just told, interhemispheric falx, and we can see this fused structure, which are the fused thalami. So this is a condition which is, of course, is named holoprosencephaly, and which can, of course, we should be recognized in the first trimester. So, as regards for the integrity of the cranial vault and the presence in the hemispheric fissure, this, of course, is something that this can be widely accepted since decades now. They can be recognized during the first trimester scan, even before the 11 to 14 week scan. But let's go to the most important assessment of the supratentorial brain, which regards, of course, the so-called anterior complexes. In order to confer the normality of the anterior complex, we should actually confer that the cavum septi pellucid is normal, this is visible, rectangular, and anechoic, that the frontal lobe are visible, anechoic, close to, but distinct from the cavum septi pellucidi. And let's see whether we can actually identify the cavum septi pellucidi, frontal or anterior ventricle. Of course, the cavum septi pellucidi is not always identified on ultrasound. It depends upon the gestational age assessment. It is difficult to identify in 11 weeks. It's more difficult. It's easier to identify so between 13 and 14 weeks of gestation. So when we do actually we assess, and this is an oblique imaging of the brain. Can you see we can see the interhemispheric fissure, and beneath the middle part of the interhemispheric fissure, we can see this anechoic opening, which is like a tiny fissure, which is put so between the choroid plexus, and of course this is the third ventricle. So you can actually assess much better here on this imaging plane. And of course, sorry. Okay, so even in this case, can you see this is a coronal view? When I do the first semester assessment of the fetal brain, I actually prefer to assess the brain from the coronal view. This is something which is commonly done by radiologists during the second and third trimester. So if we slowly go from the upper part of the cranial vault to the cranial base, can you see that at some point we can see the thalami? And this is the interhemispheric fissure, the frontal lobes, and at some point we can see such as an interruption of the interhemispheric fissure, which is, of course, the primordial cavum septi pellucidi. Of course, it's not always straightforward to identify the cavum septi pellucidi. This is actually much easier to do that during, I would say, the late first trimester, especially in 13, 14 weeks of gestation. This is another clip. Choroid plexus interhemispheric fissure. And at some point, we can see that there is an interruption in the interhemispheric fissure here, which is the cavum septi pellucidi. So we can identify the cavum septi pellucidi, not in all cases, especially in those in the late first trimester, such as 13 and 14 weeks of gestation. Of course, this identification depends upon different factors, such as the use of travaginal probe compared to transabdominal, and such other factors such as BMI, and of course the fact that the baby, so that the fetus actually corresponds to a given gestational age. But of course, the most important part of the neurosonographic assessment of the supratentorial structure is the identification of the corpus callosum. We know that this should be always done when we do neurosonography. The corpus callosum appears as a comma-shaped structure, which of course it can be distinguished by the cavum septi pellucidi by two different hyperechogenic lines. One is here and the other one is up there. Can we identify the corpus callosum on ultrasound in the first trimester? And the answer is no. It is not. We cannot directly identify that. So this is a video clip on a fetus at 12 weeks of gestation. What we can see actually is something very similar to what we see in the second trimester, in the sense that this is the third ventricle, this is the choroid plexus of the third ventricle, but we cannot identify at all the corpus callosum because it's not visible at the time. What we can do is we can apply color Doppler. In this case, of course, we can see the entire course of the pericallosal artery, and the assessment and the identification of the pericallosal artery is a very good agreement. There was a recently published systematic review including more than 55,000 cases, which of course confirm that in normal cases the pericallosal artery can be identified in up to 90%, 98, 97% of cases. So it can be recognized. The issue is that when we cannot see this sign, so when we cannot confidently, so we cannot appropriately see The pericallosal artery does not automatically mean that there is a genesis of the corpus callosum, because at the moment we have several problems in detecting the genesis of the corpus callosum in the first trimester, and such a diagnosis should not be, of course, done and should not be discussed with the patient unless, of course, the gestational age is much more advanced than the first trimester. So we can see the cavum septi, not in all cases. We cannot see directly the cavum, the corpus callosum. We can see the pericallosal artery. Clinically, I don't know, I'm not particular fan of the first trimester neurosonography. Can you see? We can easily identify that. Of course, this is a torcular and superior sagittal sinus. We can also identify other vascular structure of the brain, but even in this case, the clinical applicability is low. Let's go to the infratentorial anomaly. So when we do a second trimester assessment, what we can see and what we should see as a screening assessment of the posterior fossa is that the cerebellar hemisphere are symmetric and they are hypoechoic compared to the vermis, that the foreventricle does not communicate with the cisterna magna, that the cisterna magna has a normal size, which means roughly less than 10 millimeters, and the cerebellar and the transverse cerebellar diameters is appropriate in size. This is, of course, a video clip in the second trimester. And what we can see, the median slightly hyperechogenic vermis compared to the hemisphere, the cisterna magna, and of course these two hyperechogenic lines, which are the cisterna magna septa. And if we look in more details between the superior cerebellar pedicles and the inferior part of the vermis, we can see this structure. Sorry, just a second. Okay, we can see this structure, which is the trapezoidal foreventricle. But this is, of course, is not enough when we suspect an anomaly in the cerebellar vermis. In this case, we have also this is the algorithm we use in our clinical practice. We should look at the detailed and anatomical assessment of the cerebellar vermis, especially of the cerebellar vermis hemisphere, which implies assessment of the morphology of the cerebellar vermis, normality of the foreventricle, the presence of the fastigium of the foreventricle, the angles of the cerebellum. Also, assessment of the angles is not so accepted by many authors. The insertion of the tentorium, which is not as lost, is important now since a new classification of the posterior fossa anomaly has been released. The presence of the lobules of the cerebellar vermis, and especially the position of the choroid plexus of the foreventricle. And anatomically, we'll just quickly go through that. When we look at the cerebellar vermis, we should see that the cerebellar vermis has some flexure, and the first one is a primary flexure, which is called like that because it the first occurs, which divides the anterior superior to the posterior inferior part of the cerebellum. What is also important is to look at this structure, V-shaped structure, which is called the fastigium cerebelli of the fastigium of the foreventricle, which is the V-shaped opening of the ventral part of the cerebellum towards the brainstem. Let's go to imaging, and of course, in order to assess the cerebellar vermis, we should get a sagittal view through the anterior fontanelle, as in this case. So can you see this is the cerebellar vermis, this is the choroid plexus of the third ventricle. This anechoic line is the primary flexure, this V-shaped structure is the fastigium of the foreventricle. We can also look at the foreventricle in more detail. As can you see, we already gone through that. Can you see this is the inferior part of the cerebellar vermis and the trapezoidal shape of the foreventricle itself. These are the residual the cisterna magna septa. What is most important when we do an assessment of the cerebellar vermis in order to perform a differential diagnosis between more benign conditions such as Blake pouch cyst and conditions which are more associated with adverse neurodevelopmental outcomes such as Dandy-Walker malformation is the position of the choroid plexus of the foreventricle. So we know that the choroid plexus is present either in the lateral ventricle, third ventricle, and foreventricle, and in the foreventricle, the choroid plexus is present in the posterior inferior part of the fastigium of the foreventricle itself. So this is, can you see, the cerebellar vermis, the V-shaped opening of the ventral part of the cerebellar vermis towards the brainstem, and can you see this, the choroid plexus of the foreventricle is present in the posterior inferior part of the fastigium of the foreventricle. Why it is important? Because in more benign conditions, can you see this is the normal position, in more benign conditions such as Blake pouch cyst, it actually has the same position as in normal cases, whereas in Dandy-Walker malformation there is a dislocation of the choroid plexus of the foreventricle itself. How can we identify in the second trimester the choroid plexus? To me, the easiest way to do that is to actually acquire a actual view of the cerebellar vermis at the level of the foreventricle. So we know that the foreventricle, the upper part, so the upper line of the foreventricle is actually in close conjunction with the upper part of the cerebellar vermis. The lateral part are formed by the cerebellar hemisphere, and the lower part is actually formed by these two pair hyperechoic structure which closed inferiorly the foreventricle, and these are this is not the cerebellar vermis, but these are the chorioid plexuses of the foreventricle. Can you see how the echogenicity is different compared to the one of the vermis? We can also identify that using sagittal view. To me is much more difficult, honestly. And of course, this is a sagittal view of the cerebellar vermis. This is the fastigium of the foreventricle, the cerebellar vermis itself. And can you see this slightly hyperechogenic structure? This is more hyperechoic compared to cerebellar vermis, is the chorioid plexus of the foreventricle. Why it is important? Because in some cases, this was a case in which can you see the cerebellar vermis look like has been displaced upwards. But in this case, there is a normal fastigium. If we look in more details, one second. If we look in more details, sorry. Oh, sorry. At some point, we can see this structure here. So this is the cerebellar vermis, and at some point we can see this structure, which is the choroid plexus of the foreventricle. How can we look at all this structure during the first trimester of pregnancy? Even in this case, my advice is to use a coronal view of the brain, what we can actually easily see. So of course, we have already gone through the supratentorial structure. We can easily see the cisterna magna. You can see the cisterna magna, which is a space between the cerebellum and the occipital bone. And of course, these are other example. So these actually allow us to rule out all the anomaly involving the fetal spine. And of course, when we look in more details in the fetal cerebellum, of course, this is an oblique section of the brain. So what we can see is starting from the third ventricle, going downwards, is a foreventricle, which does not have a trapezoidal shape in the first trimester. And at some point, what we can see is the cerebellar vermis, the foreventricle. So we have here the foreventricle, the entire foreventricle in axial plane. And at some point, okay, so maybe in the other video clip. And at some point, we can see that the foreventricle is these two hyperechogenic structures, which are the choroid plexus of the foreventricle itself. Can you see how they inferiorly close the foreventricle itself? So we can also look at that by using a sagittal view. This was a slightly higher gestational age, is 14 plus something. Can you see this is the primordial corpus callosum? This is a patient at 14 plus 5, if I remember well. The choroid plexus of the third ventricle, the primordial cerebellar vermis. If we look in more detail here, which of course looks slightly hyperechogenic compared to the cerebellar vermis, this is the choroid plexus of the foreventricle. So this is the vermis, and this is the cerebellar vermis, sorry, and this is the choroid plexus of the foreventricle. So I hope to have shown you the potential application of the first semester neurosonography. As I told you, it is still controversial what we can identify with first semester fetal neurosonography, and this is because the body of evidence is not as high, as large, and the second trimester brain anomaly because of the low specificity, and especially because at the moment most published cases actually present with other anomalies, either genetic or structure, so making it difficult to extrapolate robust evidence. And thank you very much again for your attention, and thank you for being with us today.